Thank you. I really appreciate the opportunity to speak to you all, and it's good to see very many familiar faces, and certainly look forward to interact with those whom I haven't had the opportunity to meet. And let's start off with a question as it relates to what your thoughts are about devices like LVADs. You may reply, what is an LVAD? B, C, D, and E as listed. So we look forward to the audience response. So I think that's sufficient time to understand. All right, good, it's automatic. And so a little bit more than half of those here certainly would want to know more about what an LVAD is, at least in terms of not having some familiarity. And I guess the second most common is D, they can potentially be helpful. Now, when I see a patient, either for the first time or in follow-up, a patient that has congestive heart failure, specifically those that have the type of heart failure where the ejection fraction is reduced below 40%. I ask myself, well, what's the 1, 3, 5-year prognosis? Because our aim is to try to improve upon that. So I'll ask you all, how long can someone live on average with congestive heart failure, focusing in on the type of congestive heart failure with reduced ejection fraction? So if you don't mind responding, A, B, C, D, E as listed. So this is timely in that, and I think good in that there's an opportunity to be clearer to this important question, and so we'll go over this. But 37%, I guess the majority, don't know. So opportunities for us to learn from you about what we should be focusing in on. Let's proceed to my talk. And so when we have scientific sessions or we meet with residents and fellows, those in training, we always put our disclosure statement up, and I've had the opportunity to be a consultant and serve on bureaus that are paid in the context of putting forth education related to weighing benefits and risks, and I put this forth just to be very transparent as it relates to my discussion aims. And so I really want to focus in on what is new as it relates to medicines over the past, let's say, 3 years. I'm going to focus on 2 medicines in particular that have made it to the guidelines. I'm going to define what our guidelines are and how we use them. I'm going to provide an update on 2 devices as it relates to congestive heart failure. I'll spend some time to the latter part of my talk talking about what qualifies as end-stage heart failure. That's a diagnosis we don't take lightly, because what it means in terms of prognosis for patients and what's new in that field, if you will, with some focus on device technology. And so this is a busy table, but I think appropriate to highlight that for the new medicines, what is new relates to those patients that have the symptoms of breathlessness and perhaps fluid retention or fatigue that have an ejection fraction less than 40%. We do categorize or classify our patients, and I know there was a question and there's been discussion about heart failure with preserved EF, but the medicines that I'm going to highlight really are for those that have been examined, studied in those with heart failure with reduced ejection fraction. Now this slide complements Mike's in that we're obligated to do a check and balance to ensure those patients with heart failure with reduced ejection fraction are on those medicines that improve survival or decrease mortality. Those are the ACE inhibitors, the beta blockers, this other class of medications, aldosterone antagonists. And there's additive survival advantage when being on these types of medications. And dose matters, as many of you all, I'm sure, have experienced in terms of trying to get patients on the right, not only about being on the right medicine, but on the right dose of the medication. And so we, as heart failure specialists, as heart failure providers, whether it's medicine doctors or those in training or those of us that are specialized, we get a lot of good information from the guidelines, and there are independent societies like the American College of Cardiology, the American Heart Association, that review those trials that come out to put forth a stance, if you will, on where these new medications have a role or not, specifics about benefits and risks in patients with congestive heart failure. And because of the FDA fast tracking of 2 medicines back in 2015, there was an update. It was a focused update this past fall in 2016 to guide clinicians on these new medications and how they potentially can be used. And so I'm going to be talking about Ivabradine and Entresto, which I think some of you all have had some familiarity with. Now, I don't want to go into the details of the granularity of the studies we look at, and I will be commenting on what is your potential role in studies, at least in terms of considerations. And when volunteers with certain disease states volunteer to be part of a trial where our aim is to understand if this new novel medication versus standard of care offers some advantage. And so there are clear criteria that define study participation. And then if you didn't participate in a study, but then it becomes to market, you want to know if that medication may apply to you in terms of potential benefits and risks. And so as it relates to this medicine, Ivabradine, which is a new medication that in a novel way lowers the heart rate, it acts in a specific area of the heart, and it can decrease the heart rate different from how other medications we have for this syndrome lowers the heart rate. And it was examined in those that had some shortness of breath with exertion, and it was examined specifically in those that had an ejection fraction less than 35%, and they had a regular rhythm and their heart rate was still above 70. So that was the general criteria, and certainly there are a list of exclusion criteria, not only important for study design, but important for whether this applies to you or not. Now, when we design these types of trials, at the end of the day, what we're trying to do is improve outcome. If you were to ask me what's the most important outcome when you have heart failure with reduced ejection fraction, that's less than 40%, it's survival, how long you're projected to live. And while not everybody fits exactly perhaps on a curve, this is derived from studying, examining large number of patients, we want to know about how it affects dying, from a heart reason. When we start looking at what we qualify as morbidity of heart failure, for example, hospitalizations or feeling short of breath, those are important as well. And so in this trial that examined this new medication, Ivabradine, it was an endpoint including both cardiovascular death or heart failure hospitalization. And in those patients that were on the standard of care treatment, it's called placebo arm here. So they gave patients this pill that had really no underlying effect that would be positive or negative, in addition to standard medicines. But those that were on treatment yellow had a reduction in this combined endpoint. And this was largely due to less heart failure admissions. It did not improve survival in and of itself. Now, whenever we're weighing in not only for trial design, but weighing for specific patients in clinic, whether that medicine can be used, it's very important to understand the adverse events associated with this medication. And in fact, every prescription you get has a prescribing label or prescribing packet, and it alludes to those trials that define benefits and risks. And for this particular medication, bradycardia means heart rate. So the goal is to lower the heart rate in between 50 and 60, but some patients develop symptoms when the heart rate's that low. And in this medication, in having some effect in the retina or in part of the eye, some patients have some visual disturbance. This was low frequency and not a problem for most, but I reference that because we're going to want to understand projected benefits and risks. Now, I show this to you because I think it's transparency with how we as physicians look at a medication and how the experts in the field and those committees that come to review particular medicines weigh medicines in terms of benefits far, far exceeding, that's green is a go, versus consideration where the benefits felt to exceed the risk, perhaps not as to the same degree. And we as clinicians always want to avoid putting patients on medicines that are going to be harmful. So that makes intuitive sense. And so as it relates to this new medication, based upon this one large trial, in those patients that have some symptoms and their ejection fraction still 35%, and they've been receiving all the appropriate beta blockers, ACE inhibitor, and other medicines, there was a significant reduction in the endpoint, but specifically significant reduction in heart failure hospitalizations. So this has made it to the guidelines, and it's in that yellow category to where the benefits may certainly outweigh the risks. And so the aim here is to have an open discussion when you see new medicines come to market for heart failure that you think may apply to you. You may see it by commercial advertisement. Your physician may bring it up, and you're going to want to understand benefits and risks. Now, I want to spend some time over this new medication. It's called Entresto. This was based on the Paradigm Heart Failure Study, which was the largest heart failure study to date that we've ever performed over the last 20 years. And it was compared to what has been the best form of therapy for these patients in Alapril at the right dose. And I'm not going to get into the details of the underlying way this medicine works, but we have very favorable pathways that allow us to compensate when we have congestive heart failure. And so these investigators found out a way with a new novel medicine to augment those favorable pathways with the thought that it would lead to benefit. And two, when considering either being a part of a clinical trial or wanting to understand if this medicine applies to you, there are strict inclusion and exclusion criteria. And so this particular trial was defined for those that had some symptoms, shortness of breath, either with minimal exertion or at rest, the ejection fraction under 35%. This was expanded later to less than 40%. I'm not going to go into the details of the other criteria, but this trial specifically excluded those with more advanced disease, those patients that had blood pressures under 100 or were more perhaps short of breath at rest in the hospital. And so understanding exclusion criteria are key. Now, these curves I'm going to continue to show because I think they exemplify the treatment effect. And in those patients that were on the study combination drug compared to what's standard of care, and this was in addition to the use of beta blockers and other medicines, those patients that were on treatment on the study drug fared better. They had less cardiovascular-related death or heart failure hospitalization. And this was observed within 30 days. And so this was very profound and was published in one of our premier journals, the New England Journal of Medicine. And taking a step back to understand how beneficial it is, we not only look at the combined endpoints, but we want to know what I mentioned as it relates to death in and of itself, as it relates to just looking at heart failure by itself, and not going through the specifics, but these curves are all the same, that those patients that were on this new novel treatment did better than those that were on the standard of care treatment. And so for us, this is a landmark study. Now again, weighing benefits and risks, and so when I'm seeing patients in clinic that have had some exposure to this potential new medication, I focus in on what are the chances of having lower blood pressure, developing kidney problems on the drug, potassium imbalance or high potassium, or intolerance to the medication like lip or throat swelling. And so we know how it compared to the standard of care drug, and for this particular new novel medication, there is a relatively greater lower blood pressuring effect, and I think that's important to understand. So the guidelines have been updated, and remember, green, the benefits far exceed the risk, the yellow, benefits exceed the risk, and red you want to avoid. So patients that have heart failure, ejection fraction less than 40%, that are tolerating ACE or ARB, that's like Ramipril or Losartan, and have symptoms, the recommendation is to replace this with this new novel medication. But that needs to be carefully weighed to understand the benefits risk with your physician. Now I'm going to go into the the aspect of this talk related to devices. And this is a highlight in our field, in that for the first time, we have a device that we can monitor the pressures in the heart. Much like those patients that have diabetes can measure the blood sugar and can adjust the insulin to keep the blood sugar in a normal range, this device that we can place in the cath lab, and we place it in the lung artery, can give us the heart pressures, and it's the heart pressures when they elevate that cause the fluid in the lungs and the shortness of breath. And so we can monitor heart pressures in addition to what's standard, that's weights and how patients feel and everything mentioned on the prior talk, to try to adjust the medicines ahead of time before that patient reaches that critical threshold of perhaps needing to be in the hospital. And so this device can be implanted fairly straightforward. It was based on a landmark trial, which we were part of years back. And I would highlight that it gives us the opportunity for the first time to see what patients are doing at home. So patients lie on a dedicated pillow, there's a console at the bedside, and these pressures that we check in the cath lab are transmitted, the pressures actually that the device checks can be transmitted to a specific website that we or our colleagues, nurse practitioners or nurses, or Mike for our hospital can weekly review to understand if there's stability as it relates to the heart pressures. And so this is a very novel way of treating patients. And this trial was very appropriately designed. And the endpoint was looking at whether it led to less heart failure-related hospitalizations compared to the standard of care way we treat patients, that's symptoms and signs and coming to clinic and the doctor's examining you. And so again, these curves I will show, but to deconstruct it, those that had this device in, that's the treatment group, compared to the standard way we care for these patients, there was less heart failure hospitalizations in those that were on treatment. And so this led to the FDA approval of this device now more than a few years back. It was very well tolerated in terms of safety, and the improvement was above and beyond just heart failure-related hospitalizations. Patients were feeling better on this treatment compared to the usual way we treat these patients. So that's an update as it relates to monitoring devices. I'm going to transition to talk about not wanting to miss advanced or end-stage heart failure. And what I always tell my patients and what I preach to our house staff is no one thing equals end-stage heart failure. You can have an ejection fraction of 15%, and I have patients that can jog and are exercise and been out of the hospital. It's looking at your heart function, your heart pressures, blood work, most importantly, how you feel. And we look at all these factors centered around this particular heart failure patient. And we have modeling we use to try to predict prognosis. It's when these factors are pointing in the unfortunate direction that's associated with a worse prognosis where we tell our patients, well, we're concerned about you entering into that end-stage heart failure. You should not be labeled with end-stage heart failure if you have not been on aggressive, guideline, optimal medical management. So someone can come in very sick, and if it's a new diagnosis, if we have the luxury of time, we put patients on medicines, we follow these guidelines, and we try to get our patients better. So end-stage heart failure has many signs. For some people, it's being in the hospital several times. For some people, it's worsening kidney function. For some people, it's intolerance to these medicines coupled with low blood pressure. And so we go through this checklist when we are seeing our patients to understand if they have those advanced heart failure triggers. And so for those patients where all has been tried, and we think they have end-stage heart failure. For many, they're in the hospital. For some, they're outside of the hospital. There's only one of two things that will change how long that patient's expected to live and their quality of life. That's either heart transplant or one of these LVADs. And I put up this slide to highlight that we've been doing heart transplant here at our hospital since 1968. We've been doing it for decades. And on average, 50% of patients, and the adult is the green line, 50% of the patients live a little bit more than 10 years after heart transplant. Now it's trading certain medicines for heart failure for heart transplant specific medicines, and there are challenges with transplant, and you go through surgery and you have to follow up at a transplant specific center, but survivorship does look good. Now there are many reasons, some that are relative, some that are absolute reasons to not pursue heart transplant. Based on age, especially when coupled with risk for cancer or a patient having active cancer, advanced kidney or lung problems, having very high lung pressures. And so I put up this table just to highlight that we go through this in a very careful way to understand if we can't or should not pursue heart transplant because of risks. And what's been a game changer for us now over the past several years is the use of these heart pumps that assist the left side of the heart. And they're all configured in the same way in that this metal tube can be placed with open heart surgery into the left side of the lower ventricle. These new devices, I say new, we've been using them for several years, it has a rotor. In that rotor, we can adjust the speed. And it propels blood from the left ventricle into the pump, which sits under, in this particular patient, under the diaphragm, and it's propelled back into one of the main arteries to improve blood flow to the brain and kidneys. And by this pump taking blood from the left ventricle, it lowers those heart pressures. And what accounts for breathlessness and fatigue is high pressures and or low output. And so these heart pumps, I think, certainly are here to stay. And I say that because It has helped us with those that have end-stage heart failure, and that's really the tip of the iceberg. When you look at the 5 million plus patients with heart failure in the United States, half have heart failure with reduced ejection fraction. It's about 1 to 3% that develop end-stage heart failure. So here in the United States, we're doing about 2,500 heart transplants per year. Now, with these LVADs readily available, with a little softer criteria in terms of potentially receiving an LVAD, we are about 3,800 to about 4,000 LVADs across the country per year. So it is now a reality that we're placing as a community more LVADs than we are heart transplant because of risks for transplant. Not to mention that there is a limitation in donors for heart transplantation. And these heart pumps are associated on average, and these patients are sicker than those that go to transplant. A survivorship around 80%. We have several patients that are several years out doing quite well. And it helps with quality of life. This is a quality of life scale. Patients say, okay, 100's I feel great versus worse quality of life, 0. And after an LVAD out to 2 years, for many patients, several years, quality of life improves. And so we put this in perspective, and this field is improving significantly. We're very proud of our past and current research efforts. I think that patients that want to volunteer that have a specific syndrome like congestive heart failure should understand what clinical studies are available in terms of providing us with valuable information to understand whether what we're studying is associated with benefits or risks. But I point you to this website, which is an NIH initiative to guide potential volunteers on understanding involvement in clinical studies, whether there's compensation or not, and how to really put it in perspective in terms of even why or typically what the experience will be like. And we have our clinical research booth out front, which I encourage you to visit. So I've said a lot. I look forward to our panel discussion if we're still having a panel discussion, and I very much appreciate your attention. Thank you.